Postprandial. I'm sure everybody's okay, ready to go. We have 2 more sessions to go. We have a great panel today for our session number 4, which is weight bearing after fracture surgery. Are we being too conservative? Our moderator for this session is Dr. Doug Lundy, who came to us from St. Luke's, initially from Atlanta, Georgia. He is the orthopedic director and is an orthopedic traumatologist. Our panelists are the esteemed Dr. Bourne, Dr. Matt Craig from the RI at Abington, and Dr. Bob Dunbar is coming virtually from Harborview in Seattle, Washington. So, Dr. Lundy, thank you.
All right. Thanks again for the invitation to come back. Appreciate it. All right, Bob, I hadn't seen you today. How you doing, bud?
I was actually, there for sessions 1 and 2 virtually. I had finished the tongue type calc and was up. So I saw a couple of great sessions this morning.
One thing that Chris and Matt and I have talked about, we're fixing to go through a bunch of x-rays. This is not about the indications for surgery or the specifics of the fixation. We're going to judge all this on the ubiquitous thing we never talk about, which is when they weight bear. So we're going to we got a number of stuff to go through, so we're going to talk about those. All right, so we're going to talk about weight bearing after fracture surgery, and the big question is, are we being too conservative or not? This has always been an entertaining question at the part 2 of the American Board of Orthopedic Surgery, where you ask the candidates, when did you have them walk on it and why? And you get the stare of, oh man, I wasn't prepared for that question. So we're going to talk about some of that. All right. You guys ready?
Ready.
All right, here we go. So our scenarios are, we're going to run through different scenarios on this. We're going to show the x-ray. We'll make the person 22, 52, or 82. Those are all 30 years apart. We'll see if that makes a difference. We'll see if y'all think there's a difference, if the skin is open or closed, if they had a concomitant compartment syndrome, if they're smokers or diabetics. We could talk real quick about what x-rays do you get in follow-up? Does your management change if it's not an isolated injury? How significant is patient compliance on this as well as BMI? We thought, hey, it might be cool to talk about DVT real quick. What do y'all do for that? Do you use a crutch, a cane, or a walker, or a cam boot, or cast, or other things? And then Matt and I were talking, it may be a good idea to ask, when do you let them drive if it's a right-sided lower extremity injury? So here we go. We got this 22-year-old person, this non-operative ankle fracture. Dr. Bourne, let's start with you, sir. What do you think?
Well, it looks like a little bit of a possible from here, tailor tilt. It looks like there may be a posterior malleolar component, so the syndesmosis may be unstable. I don't see any air.
It's closed injury. Yeah.
Closed injury.
Yes, sir.
How did it happen? Do we care?
I'm sorry?
How did it happen, or do we care?
Twisting injury, supination, external rotation.
All right. So the question is, what would I do with this patient?
So what immobilization would you use, and when would you let him weight bear?
I want to do a stress x-ray on him because I'm worried about that posterior fragment.
Stress x-rays are negative.
Okay.
You have to suspend disbelief for this.
Oh, I can suspend some disbelief. Yeah.
So, well, the talus looks a little bit posterior on that lateral x-ray. So I think this is an unstable fracture, potentially unstable fracture. If you want to put him in a cast, you don't want to operate on him. You want to put him in a cast. I would not let him weight bear for a period of time, for probably 6 weeks, but I'd see him back sooner than that because he's probably going to put some weight on it and see if he opens up.
All right, Dr. Craig, how about you?
You gave us the prelude. So if it's a stable ankle fracture, stable to
22-year-old stable closed ankle.
So you're calling it stable and closed, but I'm suspending my disbelief because I can't believe that bimalleolar ankle fracture potentially trimale, because you can see the anterior lateral colliculus on the lateral.
I'm having the hardest time getting you guys to play with me.
I know, but
it's a question. When do you let them walk?
Really hard. It's the suspending.
I knew y'all were going to do this.
So
I'm putting this together. I'm like, these guys are going to nitpick these x-rays to death. I'm fixing to get abusive.
He and I just met today.
Yeah, we're the panel, you're the moderator. Remember
Yeah,
that.
you're gonna watch me go down on y'all.
So
It's good.
stable ankle fracture, isolated lateral malleolus, 22-year-old, put him in boot, weight bearing is tolerated, range of motion is tolerated. You could follow him up every 2 to 4 weeks to ensure that there's no displacement. I would get weight bearing. He probably comes from the ER with his injuries. We can do the stress exam, but as weight bearing is tolerated in the boot, come back, I would get weight bearing films and follow up. For DVT prophylaxis, if he was a young, healthy, otherwise compliant person, I would have non-pharmacologic DVT prophylaxis. If I felt concerned about it, probably just do a baby aspirin as an outpatient.
Oh, good. Thank you.
Yeah.
Dr. Dunbar, how would y'all doing this in Seattle?
I'd probably operate on that, but assuming it's as
Crying out
described.
loud. All right, fine. So we did operate on it. Start over, Bob.
All right. So, okay. So, I would let that bear weight, essentially immediately. If I had operated on it, I'm still, a little chicken in patients who, about their soft tissue. So a lot of time I'll see them at the 2-week mark. And if the wound's fine, I'll let them bear weight at that point. But if I'm not operating on it because I've decided it's stable, they can bear weight immediately as tolerated.
What'd you think of Nilüfer Dagan's article about this? In terms of letting them walk at 2 weeks, you're with that, or you're saying you'd let them walk?
I would say that that's essentially what I do. But I mean, there's some evidence that you can go even before that. But I have enough concern with some of my patients regarding their soft tissue, not their skeletal injury, but the soft tissues, that I will often hold them to till the 2-week mark. Yes.
In a cast boot or what?
So we'll usually put a splint on in the OR. It's a posterior splint with medial lateral plaster slabs, and we'll see them, a week and a half or 2. And if the wound is fine at that point, we allow them to bear weight as tolerated with or without a cam boot.
All right. Dr. Bourne, anything different now that we've operated it?
I'm going to want to see this person after surgery. I'm going to want to see this person back in 2 to 3 weeks, take some new x-rays, get some stress films.
So when would you let him walk on it, Chris?
Oh, you're still asking that question.
I'm going to ask you for the next.
I'm assuming that he's 29 years old. He's going to walk on him no matter what I say to him.
Right.
I don't trust him.
You know, this whole thing's about weight bearing, right?
Mm-hmm.
All right, Dr. Craig. Since I operated the fracture, you did want me to.
So he gets, I like Dr. Dunbar's explanation. He gets a splint in the operating room. You can't weight bear on a splint. Splints are slippery. They don't take up, they're not durable. They get a splint in the operating room, toe touch weight bearing post-op. Shows up 2 weeks. I get non-weight bearing films when he shows up, splint off x-rays. Range of motion, I give him a TheraBand, get their ankle moving. I put him in a cam boot, removable cam boot. And continued toe touch weight bearing till 6 weeks. Look at him. I see signs of healing on x-ray. I get a weight bearing film at 6 weeks, see that it's healing and it's stable. And then I'll progress weight bearing is tolerated full at that point.
So you don't buy Nilüfer's article then?
I'm approaching that. What I do now is different from what I did 15 years ago. So I'm a late adopter. I might be there next year. We'll see.
So you're letting them walk at 6 weeks, toe touch at 2, weight bearing at 6.
Yes. Whereas 15 years ago, it was non-weight bearing for 3 months. So
Really?
I changed.
Okay.
I'm not doing the same thing I've done my entire career. I've changed, and things like that, change my protocol.
And I'm sorry, did you say aspirin for DVT?
For the 22-year-old guy, probably do aspirin. Sometimes I've done Lovenox because they had surgery and they're captured in the hospital. We'll give them Lovenox for 2 weeks and then convert to aspirin.
Okay. Let's make this a right-sided ankle. When do you let them drive?
I tell them when you can walk and you can drive. And so there is a study out there, I can't remember their name, somewhere between 9 and 12 weeks they can drive, which correlated with weight bearing and walking. So out of the boot, can't drive in the boot. And if you can walk, you can drive.
How about in Washington, Bob? Do y'all let them drive? When do y'all let them drive?
Well, so it's not a question to let, that's between them, the DMV and their insurance company. I recommend strongly against it until they've been weight bearing for 3 or 4 weeks. but people make their own decisions. But I don't get in the middle of that. I recommend against it, but like, you know, the people are going to do what they're going to do. I essentially say, what if a 3-year-old's, you know, their ball runs across and you don't have the reaction time when you're just getting, just recovering. And then I tell them there may be that their insurance company may not support them in that situation. And that usually gets some raised eyebrows and puts a little bit of fear in them.
What if it was a workers' complication and the carrier was saying, when can this, the only thing this person does is drive, when can they drive? What do you say?
After this injury, probably not till 3 or 4 weeks after their weight bearing.
Okay, let's move on to another exciting ankle. Boom. All right, who am I up to? Dr. Craig, your turn, sir.
Open or closed, doesn't matter?
Good question. So, well, you tell me.
No, but that
Okay,
doesn't matter
so
to me, but.
For argument's sake, it's closed, but if it was open, it wouldn't change your
So
weight bearing?
you're saying it's closed, displaced, trimal with, you know, posterolateral subluxation.
Yeah, we're just talking, and all we're talking about is weight bearing and
we're fixing this
immobilization.
guy, right? We're not, this is.
Y'all
not-
operate these?
Yes, I fixed these.
Really?
Yeah. So,
Hey, so do we.
there you go. Thank you. The one posterior. Nice. These 22 stable internal fixation, congruent ankle mortise, he'd be toe touching the splint for 2 weeks, come back at 6. But then, or come back in 2 weeks, splint off, range of motion, boot, come back in 6 weeks. Then I might slow him down a little bit. And what I would say is you can do 50% weight bearing, progressive weight bearing is tolerated to full over the next month. And I see him back in a month, make sure everything's okay. And for the past 10 years, everything's been okay. That paper that he's quoting is teaching me that I'm being too conservative.
Dr. Dagan's article,
Yes.
that one? Yeah.
He
Okay.
could probably weight bear sooner than I'm letting him, but I'm learning to do that in my own practice.
So if y'all are looking for it, it's in Journal of Orthopedic Trauma. Nilafar Dagan, who's a CORE, which is a large private practice group in Phoenix. She works with the Banner Health System as well. Dr. Bourne, when would you walk him, sir?
See him back in the office, make sure the wounds are okay. He'll probably be in a posterior splint for a period of time till he comes back to the office. The splint comes off, he'll go in the cam boot. I'll have him start some range of motion exercises if his incisions look okay. We'll keep him, I'll probably see him back at 4 to 5 weeks after that re-x-ray. I will keep him non-weight bearing during that time and bring him back another 4 weeks after that. So we're out to 8 to 9 weeks. New x-rays, continue PT, active assisted range of motion, and bring him back 4 weeks after that. So we're around 12 weeks, 12, 13 weeks. And if everything looks okay, I'll start him at partial weight bearing, you know, maybe 25, 30 pounds and let him increase, you know, 25 pounds, 25% a week for every week going forward. And then bring him back at another 4 weeks, 5 weeks, re-x-ray, make sure everything's okay.
And Matt, I assume your weight bearing, I'm sorry, your driving rules are the same, right?
Yeah.
Yes.
Yeah,
If you can
okay.
walk, you can drive.
Robert, what you think, buddy?
You know, I aspire to what I said even for the other one, but I am a little bit more chicken. So I would say that I'm evolving to be more aggressive, but I think I'd be closer, you know, closer to 6 weeks probably with this. But I'd probably let them be weight bearing as tolerated at that point. But there are multiple, you know, it's not just Nilafar's paper. There are other randomized control studies that say it's fine. And these papers have sort of ramped up the aggressiveness. At the beginning, it was essentially just lateral malleolus fractures, but there are papers that include trimals. There's even ones that include syndesmotic, you know, ones with transsyndesmotic fixation at this point that are supportive of early weight bearing. So I'm moving in that direction, but like I can't say I'm there yet. But so I think I'd probably, you know, would see this patient at the 2-week mark, get their sutures out, definitely get them moving, tibio-talar, subtalar joint motion, but you know, what was effectively a dislocator, right? With a trimal, I'd probably be closer to 6 weeks.
Yeah, thanks, Bob. That's good. And as you could tell, it was a pretty substantial injury with a lot of crummy bone stock as well.
Yep.
Very good. Thanks, guys. All right, let's move on to something else. Let's do something a little different bone here. 31. All right, intertrochanteric femur fracture. Let's make this person 82, since it's unlikely this is a 22-year-old. So you could see the injury films. I'm sure your hospitals get much better injury films. This is called sarcasm if you've never heard it before. Then we have the fluoro shot on the right. You can see how it was a little challenging at like valgus. And then we stuck this device in there. Dr. Dunbar, I'll start with you. Weight bearing, sir.
That patient is weight bearing, is tolerated, full weight bearing. I mean, the elders can't do protected weight bearing. And, you know, there's this old saw that if you left the room and we're not going to make that patient weight bearing, is tolerated full weight bearing, maybe you did the wrong operation, right? But I let this patient weight bear immediately.
Walk to PACU, right?
Yeah.
DVT prophylaxis, Bob? 82.
You know, I got two of the authors from Prevent Clot here in my as my partners. So this
That's right. I didn't think of that.
so we would they'd get aspirin.
So you buy so it's 81 BID? Because
I think that's right.
I mean, that's what the study showed, but that's what y'all do?
Yes.
Okay, so you do that post-op and then go home with it, or that they got Lovenox in the hospital and then go home with aspirin?
You know, maybe pre-op they'd be getting Lovenox, but post that's correct. Yeah, that's correct. They would leave the hospital with aspirin.
But in the hospital, they might get Lovenox or something else?
That's correct.
And y'all forgive me for abusing all these brand names. We don't mean to do that. We're not advocating for any of them. All right, Dr. Bourne, sir, what would you do in terms of weight bearing?
I agree with Dr. Dunbar. I would let this patient weight bear immediately. Full weight bearing, as he said, you know, in this age group, it's hard for them to do protected weight bearing anyhow, but this is a very stable construct, very stable injury. These patients I would see back every 4 to 6 weeks for x-rays. If it's 4 or 5 months, they would continue to have pain. I'd get a CT scan to make sure that they have union.
DVT prophylaxis, Chris?
Aspirin.
Okay.
Lovenox in the hospital, aspirin on the way home.
81 BID?
BID.
Or QD, okay. Matt, how about yourself? Anything to add?
Weight bears tolerated with the walker. You can throw that in there if you want. Call it weight bears tolerated, fix and forget. They get staples.
Fix and forget.
Fix and forget. It's an intermittent nail stabilization of the femur. These 99% of the time, this can be fine. So weight bears tolerated. I see them back at 6 weeks, get an x-ray, and lately I've been seeing people back at like 4 to 6 months with confidence that it's going to heal. If they have problems, they're welcome to come back sooner, but the elders can have a challenge coming back for all these other visits. I do Lovenox 40 a day, 2 weeks after discharge, same way every time. So I don't forget, the residents don't forget. Maybe I should be adopting an additional protocol that's easier for people, but I just haven't changed yet. But Lovenox for 2 weeks and then aspirin up to 3 months.
QD or BID?
Q-day.
Q-day. So you're saying, because if you read the Prevent Clot study, the reason they went BID was to match the same dosing parameters as Lovenox, which was twice a day.
Right.
And you're saying that once a day is
But
fine.
The
the
pharmacology of Lovenox and aspirin are different.
Yeah. So
I've never understood why we do aspirin BID.
Well, I think
It's
the
been
only
pulled out
reason
of the
they
sky.
did it in the study was because since they were given Lovenox twice a day, they felt to keep it the same in terms of compliance and stuff
Okay.
like
I
that.
do Lovenox 30/30 versus Lovenox 40 a day pharmacologically is the same and the outcomes are the same. Aspirin twice a day and aspirin once a day, the half-life of the platelet is 2 weeks. So I'm not really sure what you're getting from the second dose of aspirin during that time.
You know, the reason why, so the initial people who did aspirin 325 BID for joint surgeons, actually Paul Lockheed was filled up, who was my partner. And the reason he selected BID is because he didn't trust people to take it once a day. So he said, if you take it twice a day, maybe they'll take it once.
Yeah, so which means none. So the idea is the cardiac guys have been doing aspirin once a day for decades and it's been fine.
Yeah.
And
the
they cut down
Prevent
from
study
320
was to make the arms the same.
And they went down from 325 to 81 because the efficacy profile was the same and the side effect profile was different at 81 versus 325.
So I'm with you, Matt. I'm a QD person as well,
Yeah.
but I understand the BID thing because then it
Once
takes
is
people
good,
back
twice
to the
is better.
study.
It's like an orthopedic mantra, but it's overtreatment.
All right, we've worn this one out. Let's move something else. Oh, floating knee. We have this left-sided
Ouch.
diaphyseal femur fracture with an associated bicondylar tibial plateau. All this is closed. Let's go back to 22 years of age. Dr. Bourne, I think I'm back around to you, sir. Oh, let me show you some fixation. So we retrograde nailed the femur. Bicondylar plated the tibial plateau. When you can let them walk.
Well, the rate limiting factor here is going to be the plateau injury. It was just the femur fracture. You let him walk immediately. The plateau injury, I will let these, heal up or start them on PT with range of motion, both the hip and the knee and the ankle, and see the patient back in the office probably 2 to 4 weeks post-op, continue PT, keep him non-weight bearing, and I would keep him non-weight bearing, no matter what the literature says. I keep him non-weight bearing for probably 12 weeks.
So
Very,
12
very
weeks.
Very conservative. I'm old.
12 weeks, immediate range of motion, right?
Yep.
Okay. And DVT, are we still on aspirin or
Lovenox for a month.
Lovenox? Okay. Cool. Matt?
I agree with Dr. Bourne. Limiting is the plateau here. If it was the nail only, femur only, we'd weight bear tolerate. So,
weight bearing is tolerated for 2-pack if it was just the femur.
Just femur, right? Fix and forget. However, I'm going to treat this bicondylar tibial plateau fracture. So early range of motion, toe touch weight bearing, the weight of the leg can rest on the ground for balance. 6 to 8 weeks of toe touch weight bearing and progressive weight bearing, the goal being fully weight bearing by 10 to 12 weeks.
So at 6 to 8, you progress the full by 10.
Yes, it's usually written down of you do 50% now, then add 25% every 2 weeks until full and so forth, and as tolerated. Yeah.
How do you tell patients to measure their 50% weight bearing?
Stand up. Half your weight's going through each leg. If you put one foot down and lift the other foot up, that's 100% on that side. So you can stand at the sink, you can stand up and pull your pants up.
And when
You
they
can't go
when they move
50, sorry, go ahead.
when they move from the sink to the stove.
They're walking with the walker or crutches.
Okay, you explain that to them, I hope.
Yes.
Okay.
I essentially say that 25, 50, 75, 100 means a little, some, a lot, all. So, if we're doing progressive weight bearing by that, that's about as specific as I can be.
Speaker on speaker combat. This is awesome. All right.
It
Not at
gives
all.
the therapist
Not at all.
something to do.
Nothing but love.
Come on, Bob. I'm trying to spin it up a little. Go ahead, Matt.
It gives the therapist something to do. You're changing their activity in the physical therapy sessions. They're not doing the same thing for weeks and weeks and weeks. Now, at 6 weeks, they changed to partial weight bearing. Great. Come back at 10 weeks. Okay, now we can do more weight bearing. It's kind of evolving and changing as they are healing. They're putting more weight on it. We're not waiting for entire healing to stop or to be finished as your weight bearing. So as their healing is happening, you're allowing them to put more and more weight on it.
All right. So Matt, I'm sorry, I lost it in there. What you said there, you progress them to full weight bearing by 10 weeks. They're
10 to 12, yes.
10 to 12, and they progress it at 8. Is that right?
Can depend for this. If this was a younger person, might start at 6. If it's an older person,
22 years old, and you were satisfied with the fixation.
yes. So progress weight.
And
So
this
start
is
at
what the
50%.
x-rays look like the whole way through in terms of stability and maintenance or reduction.
Correct.
All right.
Yep.
Robert, what do you think?
So there's a couple things, right? I completely agree with essentially what everyone has said, that this is all about the bicondylar that's has the potential to limit weight bearing. This is a 22-year-old, so they should have the upper body strength to be able to do that. Not every 22-year-old does, but maybe they do. But for me, one of the biggest things that are weight-bearing restrictors are re-elevated impacted segments of osteochondral fragments that we need to come together. If they weight bear, there's still the concern that if that subsides, that's probably a terrible outcome, right? And even on the medial side, these coronal oblique, what's common in a bicondylar on the medial side, those are very vertical fractures that are subject to shear forces. So like for bicondylars, I have not moved off our essentially 10, 12 weeks of non-weight bearing if I've re-elevated, multiple or even, a one osteochondral fragment on the lateral side that was, a couple centimeters down. I need that to sock in. Now, you can say, and there is support. There's a paper, Williamson, like a few years ago, had a paper where they were weight-bearing plateaus essentially immediately. And there was support for that. But for me, on plateaus and pelons that have impaction, that's going to be, I'm going to need to see more evidence that works before I join that party.
I will say that anecdotally, my daughter had this fracture, was treated this way, didn't have a femur fracture, but just had the bicondylar plateau fracture. 36 years old, healthy otherwise. And she was postoperatively cared for by some guy named Mehta here in Philadelphia. And Samir kept her non-weight bearing for 12 weeks. I don't mean to throw Samir under the bus because he's not here, but that was his protocol, 12 weeks non-weight bearing. He's not on the panel.
He was on this morning.
So, if not here to like throw people on the bus. So apparently in Parkland in Dallas, Dr. Starr talked about the fact that people don't speak English, and he gets a cadre of residents coming through all the time, and it's just no camina, for 3 months. So sometimes you have to do the best you can in the environment that you're in, and make it work. If I can educate my patients and do what they can do with therapy and everything else, that'd be great. I'd like to advance things, but sometimes you can't.
If this is a simple split in the articular surface at either end of the tibia, that may be different, right? That may, at least, I'm not going to go 12 on a simple split, right? I'd probably go a max of 6. And, don't be surprised if the paper is coming down the line that says you can probably bear weight on that close to immediately. But the depressed articular segments that we've re-elevated back to where they go, to me, that's a little bit different.
All right, Bob. Oh, I thought that was the one. I got a simple split coming up. Why don't you take this one, Bob? We got this periprosthetic proximal femur that we assaulted with this plate and cable construct.
This patient is an elder.
Let's go 65.
Yeah, if
A little bit in the middle. That's not elder. It's a little bit in the middle.
no, I agree, but I still think that if you've got dominant fixation, then I would have this patient be weight bearing as tolerated. I mean, you have to balance that against, like, what if that didn't work, right? Can this patient tolerate a second procedure? You said 85. I'm still going to say get them up and moving, but I might fix them more with everything I got so that I feel comfortable doing that.
Right. That's why I aimed at 65, was to kind of push you in the middle there.
Yeah.
We'll drop
better bone, right? Better bone. So weight bear on it.
Thank you. Chris?
I agree with Bob. Yeah, you've got a fairly simple fracture pattern. You've got a big spike. You've brought that down. You've got more cerclage wire than I've ever seen in my life, in addition to the plate.
I told you we don't talk about the fixation.
I didn't say anything.
Okay. Whatever.
But you have excellent fixation on this, and I will let this patient weight bear immediately.
Matt?
Yep. Weight bears tolerated. It's like a nail plate combo. It'd be great. Weight bears tolerated. It's almost the avoiding the repetitive active abduction that's going to bother him. Weight bear is fine.
Very good. All right. Here's another periprosthetic femur. Let's go. Well, we got a hip above and knee below. Let's make this person 65. Okay. Did this. Matt, what do you think?
I don't like it.
You do or you don't?
I don't. I think the plate's too short, but we're not allowed to criticize its fixation. If this person showed up in my office having had surgery somewhere else and I saw this, I would limit their weight bearing. However, if I had to fix this with a longer plate, it goes all the way up to the stroke with better fixation, I'd let them weight bear as tolerated.
Yeah, this was the longest plate we had. There was nothing longer. So you are, so you would be, so how would you limit their weight bearing on this one?
That's a short segment fixation above that nail, above the total hip proximally. I'm cautious about when they start weight bearing on this. There's just the lever arm on that area with the stiff hip, the stem in place. I'd be worried about it displacing. So I'd like to see more fixation proximal to the fracture site, so it's more balanced. But if they showed up in my office, I might limit their weight bearing until I see signs of healing on X-ray, which takes 6 to 8 weeks. And then I know that it's stable and healing and hasn't moved. Then they can progress the weight bearing as tolerated to full. So probably toe touch for 6 weeks and then progress.
Okay, Bob?
You know, I would have to agree. You know, like I think we're a little lean at the top, but you know, unless I'm misjudging that, can I see the original films first to see if we've got how much? And now come back to the fixation, please. Yeah, you know, I mean, certainly if this was somebody I really didn't want to operate on again, or I thought didn't have the reserve to undergo that again, you know, I'd be happier with that plate going all the way to the top. So I think I would agree.
So agree to what?
I wasn't,
Touch?
if I wasn't there and I didn't see it and know that it was bomb-proof myself doing it, I would be hesitant for, you know, make them toe touch if at all possible, for, you know, 4 to 6 weeks, probably 6 weeks. And then if it's making it, then I would progress them to full weight bearing.
All right, so we're arguing over a couple of holes. Let's suppose the plate was 2 holes longer, just up under the greater trunk.
That tips me the other way, Doug.
Then your weight bearing is tolerated?
I want to be, so yeah, if I had a couple more screws in that proximal segment, I probably would.
Okay. Matt, you had 2 holes?
Well, if I had my opportunity, I'd actually plate it from the top down because I think the fracture is more proximal than distal. So I'd plate it from the top down. So if I was, like Dr. Dunbar said, if you know it's bomb proof, let them weight bear right away. What I've done recently was to allow people to weight bear as tolerated for transfers and toe touch during ambulation. So I know they will get out, at least get out of bed. The nurses will get them out of bed. If they are toe touch or non-weight bearing, the nurses won't do anything, but the nurses feel safe that they can at least transfer without the presence of a therapist. Weight bear is tolerated for transfers and then toe touch.
All right, Chris?
I like that plan. I think that this fixation with I hate to talk about fixation. You've already spanked me once, spanked me twice now. You know, you've got more cerclage wire than I've ever seen before, except for the last case. And I think this fixation is not bad. I would let this patient be weight bearing, partial weight bearing to get out of bed, move around, start them in PT, hip, knee, and ankle, bring them back, re-x-ray them, make sure everything is stable, and then progress their weight bearing in about 4 to 6 weeks to full
Okay.
weight bearing.
Let's see what's next. Oops.
Let me ask a question, Dr. Dunbar.
Yes, sir.
A couple more holes in that plate going higher. How much better fixation do you think those screws really get?
You know,
Let me finish. The higher you get.
The bone gets worse
Speak-
way up in the
speak-
trunk for sure.
Speak to me.
But in the calcar, it's pretty good.
Okay.
All right, are we good on that one?
I am.
All right, great. All right, let's go to this tibia, proximal tibial fracture. Who am I back around to? Chris, are you? Let's start with you, Chris. What would you do? So here's your fracture. And here's fixation. Oh, he had a compartment syndrome too.
Can you go back to the original film, please? Well, here we've got the Dunbarian impacted fragments that we have to think about in terms of weight bearing, and I'm pretty conservative. So if this thing is essentially anatomically fixed, those fragments take a while to heal in. I'm going to keep this patient on weight bearing for 12 weeks. Irrespective of compartment syndrome, that doesn't really play into this. It's the fixation and the bony injury.
Bob, I think you published on these injuries with compartment syndrome too, right, Bob?
No. I mean, yeah, I think there's a paper from our group. I'm not on it.
But you were on there. Okay.
But yeah, thanks. But no. I agree with Chris. Apart that plateau. If we were just talking about the proximal shaft or then I'd probably let them bear weight with either a double plated or an intermedullary nail. But in the setting of that articular fracture, I would also keep them off of it.
For how long?
Probably the better part of 12 weeks. In a young person, maybe 10.
And the compartment syndrome affects you nothing, or
No,
what?
I mean, I think it increases the rate of infection. You may have a wound problem that you may be dealing with. They're probably slower to mobilize, but it's not going to change when I weight bear them.
Okay, Matt.
A similar approach to before. It's a paraarticular fracture, so it's allowed to be toe touch weight bearing. Just the weight of the leg can rest on the ground for balance. 6 to 8 weeks, slow progressing weight bearing with the goal of being full weight bearing by 10 to 12 weeks from surgery. Compartment syndrome doesn't change what I do, other than maybe reminding them he's going to be more prone to stiffness, I would say too. There's the wound healing concerns as well, but ankle range of motion, knee range of motion, vitamin D, and yeah, kind of stick with my weight bearing the goal would be weight bearing at 3 months.
You're my DVT guy. What are you giving here?
I guess it might judge what his severity of injury was. If this guy's a 3-limb extremity fracture kind of guy.
Say it's isolated. This is it.
So then he gets Lovenox 40 a day, 2 weeks after discharge, and then aspirin once a day up to 3 months. So then by 3 months, you're air quote normal because you're walking.
All right. Oh, let's do a little pelvic ring stuff here. What do you see? Let's see. Back to Robert. Back to you.
Full disclosure, I have 3 colleagues, or actually now 4, who do all of this stuff for us. We have a busy shop for pelvis and acetabulum, but I'm not one of the folks doing it. But what I would say is that this is a pretty significant injury, and if this was more of a rotational injury, I'd be more inclined to weight bear a patient early. This patient's off this for. In my recollection of what my partners do is a minimum of 8 weeks.
Yeah, I think you're right. Based on my talking with your partners. Dr. Bourne.
Transsacral screws, plate in front. I agree with Dr. Dunbar. Still the stresses on the posterior sacral area are significant. For weight bearing, I would keep this patient on weight bearing or touchdown weight bearing for 12 weeks.
Even though it's a sacral fracture, not an SI joint injury.
Yeah, sacral fracture.
Mm-hmm.
Yeah, I think that the sacral fracture is going to heal more robustly than an SI joint injury. So that'd be range of motion is tolerated. I'm perceiving this also to be a left-sided injury, so he's toe touch on the left, weight bearing on the right. Looks like he had an X fix on it.
Yeah, it was left-sided. Yeah,
but it's also
a fracture. So
fracture. I mean, those things like to heal. So I would be 6 to 8 weeks for toe touch, and then progressive weight bearing is tolerated to full after that.
6 to 8 weeks of toe touch.
Correct.
Then you go to weight bearing from there.
Progressive weight bearing is tolerated to full, and as tolerated means if it hurts me to do that, don't do that.
So you're progressed. Help me understand how quickly do they progress?
So that's
'Cause you like
changed
to
over my
progress.
mantra. I used to have it all written down, do 25% for these 2 weeks and then do 50% for these 2 weeks, and then do 75% through these 2 weeks. And I said, come back in a month. And I looked at everything and this is my own personal internal thing that everything was fine. Okay, start by doing 50% and then go to 75%, come back in a month and everything was fine. Okay, now say, okay, I feel confident about it. Say, all right, progressive weight bearing is tolerated to full, and they'll auto-regulate. The hip fracture studies from years ago showed us that patients will auto-regulate. It's been okay, especially with the sacral fracture. He doesn't have SI joint injury. Doesn't have vertical instability. This is a partially stable fracture pattern. They can tolerate some more stress, and there's been recent literature to show that.
All right. How about DVT? What are you going to do? This is kind of a
So
different
the
game.
number one recommendations from the chest physician guidelines is have a plan. It doesn't tell you what plan to have. It's have a plan. 40 a day, 2 weeks after discharge, and progress. Then start aspirin 81 a day up to 3 months.
So 40 a day.
2 weeks for
2
Lovenox,
weeks.
40 a day. I'd rather have myself stuck with a needle once a day than twice a day. So 40 a day, 2 weeks after discharge, and then progress to aspirin after that. Then the idea is, and nobody remembers when they started the Lovenox. Everyone remembers the day they discharged from the hospital. So I would just tell everybody it's 40 a day, 2 weeks after discharge. If you want to do 21 days or 30 days after discharge, I don't bother you with that. You're doing something, you have a plan, and that's your plan, and then reassess your plan. Is your plan working? Great. If my plan of two weeks after discharge, I'm getting DVTs at 21 days, I should be doing something different. But if I'm not having problems and what I'm doing is okay, then that's okay. It's different for everybody. But have your plan and then be consistent with your plan, and then reassess your plan.
All right. Dr. Bourne, DVT prophylaxis.
Lovenox during the hospital, post-op for probably 4 weeks, and then nothing. It's going to be mobile.
And then what?
Nothing.
Nothing.
No.
4
no,
weeks and then they're just walking or just be immobile.
Right.
Okay.
So this guy's weight bearing is tolerated 4 weeks.
No,
He's
no,
working.
he
He's
said 10.
he's on the right side. He's weight bearing is tolerated. The left side, he's going to be touchdown weight bearing.
Or you said 12, right, Chris?
I did say 12
10, 12.
initially, but I'd still let him, weight bear on the right side. I think you're correct on that. I accept that. The my thing about not weight bearing for 12 weeks was focused on the left side.
Gotcha. Bob, DVT prophylaxis.
I think we'd do Lovenox in-house and then would go to aspirin BID up to 6 weeks post-injury.
Love it. So that's what Saji's doing too? As far as you know?
I honestly don't know. He's been gone now 6 years.
Oh, I'm sorry. Yeah, I'm dating myself on that one. Whoa, sorry.
Yeah. He's in Cincinnati with Mike, but
Try.
but that's what Reza, Connor, Mike Githens, and Erica Roddy are doing.
Oh, that's right. That's right. My bad. All right, let's see what else we got here. Oh, little posterior wall action. Posterior wall acetabular fracture. You can beat this one up if you want. I didn't do it. My partner fixed this one. Good fixation, good stable joint.
Is that an ACDF plate?
I don't know what he did.
All
He's
right.
good. He's a good guy. He knows what. I don't know what it is.
Yeah, it is.
Huh.
I don't micromanage him. As long as you're fixing him, I'm fine. All right, Robert. I think I already had you. Chris, what are you gonna? How soon are you gonna walk him?
Posterior wall fracture. It looks like you have good fixation on this. I think the dome otherwise is pretty reasonable. And I'd probably let him out of the hospital, touchdown weight bearing for 4 to 6 weeks, and then full weight bearing after x-rays.
What if I put cerclage wires on it? Would it be better?
I think a couple of cerclage wires would really do nicely there.
All right. Matt, what do you think?
Toe touch weight bearing on that side. Hip flexion precautions, I do 90 degrees. If I get really worried about it, I might say if he actually dislocated, I'm concerned.
Okay, so let's pull that. That's a good thing. All right, so he did not dislocate, and intraoperatively he was rock solid stable. What's your posterior precautions going to look like?
I still make him 90. So it's kind of like a little box you put people in called hip flexion precautions, 90 degrees. And so the therapist, the nurses, everybody understands what that is, whether you did a posterior approach for an arthroplasty or you did this. So you're just sort of, people are seeing something that they're familiar with. So I'd just say hip flexion precautions, right lower extremity, toe touch weight bearing, back in 2 weeks, staples out, x-rays looks good, come back in a month. Now we're at 6 to 8 weeks from surgery, signs of healing on x-ray, begin progressive weight bearing. And then
Okay.
hip flexion precautions come off at 3 months.
Any thoughts, Bob?
Again, this is not my wheelhouse, but I did ask Reza what and because we're do clinic together. So typically those patients are toe touch weight bearing for 6 weeks, and then they progress to full over the course of the next 2 to 4 weeks. In terms of hip flexion precautions, they're not as aggressive with that as they were 15, 20 years ago. But I still think that it's at about 90. They'll limit them to 90 for the first 6 weeks.
All right, let me see if I can find that split plateau in the slight seconds we have. All right, here we go. Well, no, that one's a split. Yeah, all right, we'll do that. Still has that joint depressed segment. So Bob, this is the same one you were talking about before, because you got to lift that elevated segment. You're gonna,
it's interesting though, where that is depressed. If you reduce that, I'm moving it towards, if you reduce that and get the condyle width right, the femur is really going to bear weight on that intact wedge. That's why getting the condyle width right, I think, is so important, because if you don't, then that vulnerable piece that got impacted is still lining up with the distal femur. So if you can get that in, as you've done here, it's probably going to be fine. But I'll admit I haven't moved to that yet. But I bet you that's fine to do early weight bearing on that, because it's a lot of that's gonna rest on the restored lateral wedge.
do you augment with calcium phosphate or anything?
We use cancellous allograft.
Got it. All right, Chris, anything different? Because we're almost done.
No, I like, I respect what Bob's saying about the rim being intact, and so the weight bearing is going to be going through that outer area. The impacted fragment will probably be left alone, but I'm still scared, because you want to give this person the best result possible, and I would give him touchdown weight bearing at 4 weeks, and then full weight bearing at 12 weeks.
And Matt, you have the final word.
Same thing, toe touch weight bearing for 6 weeks, and then progress weight bearing as tolerated to full.
Gentlemen, thank you very, very much for humoring me here and playing with this little activity. So thank you very much.
All right,
Thank you, Doug.
So real quick. You're the moderator. You went through a ton of cases. I loved it. Question was, are we too conservative with weight bearing? I'm going to fire away 3 questions for you. Periprosthetic distal femur fracture, fixed with a plate. When do you weight bear them?
Right away.
Right away. Doesn't matter the age, bone quality.
Nope.
Bimalleolar ankle fracture, ORIF, decent bone,
2 weeks.
2 weeks. Okay. Plateau fracture.
6.
So questions. Are we being too conservative in your mindset?
So I was in a progressive group when I was down south that started pushing the envelope on it. I understand what these guys are saying, but we started pushing that edge to see what it was. There's a lot of, you hear the sage advice from Dr. Bourne pushing the other way on it. I think that in the near future, we'll have this better worked out.
So for all the students in the early residents here, topic was picked because you have academics, people with a lot of experience. Everyone on the panel has experience. They're involved in academics. They've published papers. They're involved in multi-center studies, and there's still no agreement. So I think we all learn from that, whether it's DVT, weight bearing, all throughout the spectrum. So I thank you guys very much for your input.